Hi, everyone. Welcome back to the Career See Me podcast. I'm very excited to have Dr. Wagner on with me today. So I will go ahead and let Dr. Wagner introduce themselves.
Hi, I'm Elena Wagner. I use pronouns she, her. I'm a minimally invasive gynecologist, which means I'm a gynecologist that specializes in kind of benign, so not cancerous gynecology with a focus in surgical management of gynecologic problems.
Awesome.
Yeah.
And if you feel comfortable, we love to ask folks how they like their gender identity or like any of that kind of stuff if you want to share.
I'm a cisgendered woman, and I identify as a straight.
Awesome. Thanks for sharing. And then how does your work that you do with minimally invasive gynecology overlap with trans healthcare?
Absolutely. So in the in surgical realm, a lot of folks are potentially interested in gender affirming surgical management. And that may be a hysterectomy, that may be an oophorectomy, removal of the ovaries, hysterectomy, removal of the uterus, and then, or potentially surgical sterilization, removal of the fallopian tubes, which is called a salpingectomy. In addition, I have a lot of patients that may have kind of standard gynecologic problems and that need management, endometriosis, fibroids, abnormal bleeding, and then that may be a little bit more complicated if somebody is on testosterone or other hormonal medications that can affect those pathologies.
Yeah. So, and our target, I should have maybe told you this beforehand, but our target audience is like community clinicians. So providers who manage typically primary care or hormone prescribing for trans and gender diverse patients. And so, you know, when is like a good time for them to think about referring people to someone, you, if they're in your community, or someone like you in their own community?
Yeah. So certainly if somebody's interested in surgery, they're generally speaking, for folks that are coming in looking for a gender affirming surgery, a lot of times they are going to be offered a minimally invasive approach just because tend to be in the younger end of the spectrum. But there are a lot of folks that may be offered an open procedure, an open hysterectomy, and for benign, not cancerous reasons, if somebody's being offered that, they probably should seek a second opinion with somebody who has additional expertise. So certainly if they're interested in surgery or interested in learning about surgery, I think that's another confusion that patients have more so than providers, is that if they come to speak to the surgeon, that means they're committed to having a surgery done, whereas it can also just be an opportunity to learn like what that looks like and what recovery would be like, and what to think about going into that sort of thing. So anybody that's interested in talking about surgery is an appropriate referral. I think that in general, referral for kind of the more complex gynecology end of things, certainly I'm happy to have, I think probably where it gets tricky from a primary care provider or referring provider standpoint is when kind of the first line normal stuff that people have tried doesn't work would be one scenario. So, a lot of patients with vulvitis, ruled out infection. There's a lot of other things that can cause itching. So that's kind of a good place to refer. People that may have a lot of challenges with pelvic exams is another place. Not every primary care provider is going to have a pediatric speculum available to them, or other kind of tools that we can sometimes do a more comfortable exam in folks that aren't regularly engaging in vaginal penetration. And then in kind of the more, of course, we can also offer an exam under anesthesia in the scenario where a patient just really can't tolerate anything in the office as well. I
have 72 follow-up questions already, so I'm totally going to be the doctor that interrupts the other doctor. But first, okay, I want to come back to like trauma-informed pelvic exams, because I definitely want us to like focus on tips and tricks for providers.
Yeah.
But before we do that, I want to go back to one of my other questions, which was like, what's kind of the like risk benefit, pros, cons of minimally invasive versus open hysterectomy, and who, and like follow up to that is like, as referring clinicians, like who should we think about like maybe siloing more towards open versus more towards minimally invasive?
So for benign surgery, and that, of course, cancer surgery is a whole different ball game. But really, most people should be able to have access to a laparoscopic or a vaginal procedure, even. And one thing that I've been really excited about is a vaginal laparoscopic surgery, and so it's called a V-nodes hysterectomy, and so there's no abdominal incisions, which I really think is going to increase the availability of a vaginal hysterectomy for folks that may not have been a good candidate for a traditional vaginal approach. So that's one area I'm kind of excited about. Folks that may need an open procedure are going to be people that have a complicated surgical history. And then probably the biggest one would be a big giant uterus, like a big fibroid uterus, and then, or people that have maybe really complicated endometriosis. A lot of times the benefits of seeing somebody like a minimally invasive gynecologist is that we've done additional surgical training. Most of the hysterectomies done in the US are done by people that do less than 10 hysterectomies a year. And we all know that the more often you do something, the better you are at it. And so the minimally invasive surgeons tend to be more high volume. And so somebody who doesn't do as many hysterectomies may not be as comfortable tackling a 500-gram uterus, for example, with a laparoscopic approach, whereas somebody with my training feels very comfortable doing that.
All right. And so when we just, to clarify for our listeners, when we say complicated surgical history, we're specifically thinking abdominal pelvic surgeries. Yes. So just for anyone listening, I know most of us are clinicians, but we're not talking about they've had rotator cuffs like multiple times or knee replacements multiple times. We're talking specifically abdominal pelvic because of the scar tissue adhesions and all of that kind of stuff that can make it more complicated. And then I didn't know that most hysterectomies are done by people who did less than 10 a year. I'm wondering how much of what kind of outcome differences there are from an open versus minimally invasive approach. Yeah. And then how much of those differences do we think are related to it being less invasive, and how much of it is just you do so much more? So
probably both. But in general, the open procedures, an open procedure is going to be something I always, a lot of my patients have had something like a C-section to reference that to, but it's a much longer recovery. There's significantly more pain. There's more risk of things like bleeding and infection as well. And blood clots, DVTs are all more present in open procedures.
Okay, nice. For us to know about. And then I feel like one of the other questions that I always get asked, by my patients is kind of amount of time to prepare off after surgery, and with hysterectomy, I usually say 2 to 8 weeks, and it depends on, what kind of work you're trying to take off of.
Absolutely. So I usually tell my patients if they're going to have a minimal invasive, either laparoscopic or vaginal surgery, I also tailor it to kind of what they do for work. So I usually tell people if they are somebody whose work or have the option to do work that mostly involves sitting at a computer, nothing that involves heavy lifting or physical or being on your feet all day, I tell them 3 to 4 weeks to plan on 3 to 4 weeks before they're feeling up to going back to work completely. There's certainly a subset of folks, and I think especially with the more flexibility with working from home, that are getting back to work week 2 from answering emails, maybe working a couple hours a day standpoint. And usually by 2 weeks, they're physically feeling pretty well. They're not having a lot of pain. They're up and moving around okay. But they probably just get tired really easily, and kind of a long day of work will tucker you out more than it would have before surgery. And so usually 3 to 4 weeks for planning purposes when you're going to feeling back to kind of less fatigue, able to go a whole day of work, that sort of thing. And then I tell people 6 to 8 weeks if they have a significant physical component of their job. So as the top of the vagina heals, we want to let that rest before we put a lot of pressure on it.
Okay. And then as far as, I had another question. Give me 1 second. My brain will catch up. Oh, sex after histo, BLSO. I think one of the things that like most physicians are bad at talking about is sex. That's just like true. Like, I don't just think it, like the research shows we actually suck at it.
Oh, absolutely.
But definitely as referring clinicians, I think like one of the jobs I try to do is like talk about the things that maybe your surgeon will forget to tell you about. And so like ask them about these things. And these are the things I already know about them. So like, what does your counseling kind of look like for patients? Like this is like kind of things to expect after.
Sure. And so, yeah, totally. I try to be proactive and bring up the sex component because sometimes people feel awkward asking about it. But it's definitely something everybody wonders about. So one question people always have is kind of once everything is said and done and I'm healed, what is sexual function like? How is sexual function going to change? And so generally speaking, the best predictor of having a satisfactory sex life after hysterectomy is having a good satisfactory sex life before hysterectomy. I tell them we don't touch any of the external genitalia, so wouldn't expect any changes from an orgasmic standpoint there. Depending on why they're having a hysterectomy, if they're having pain, if they're having bleeding, all of those reasons, all those symptoms tend to be a negative effect on sexual satisfaction and comfort during intercourse. And so if we remove those negative aspects to sex, then a lot of times sex gets better after hysterectomy for those folks. For people that are, looking or more maybe don't have pain or bleeding and are looking more for gender affirmation, sometimes I think removing the risk of like an unplanned pregnancy actually can be really freeing and make people remove one more kind of break when they're engaging in sexual activity, if that's a concern at all. For after sex, I usually see people back at 6 to 8 weeks and do an internal exam to kind of look at how the top of the vaginal canal has healed and give them the clear for penetrative intercourse. I'll have a conversation with folks that maybe aren't engaging in penetrative intercourse or don't want to engage in penetrative intercourse in the future about kind of pros and cons of doing that part of the exam. And sometimes we'll skip it if it makes sense for that particular patient. A common question I'll get is, well, if I don't do any penetration, when can I do external stimulation or other sorts of sexual activity? And so, I usually tell folks the main reason and I also try to tell people why I don't want them to put things in their vagina, because that helps them understand. Sometimes I've had patients get into a, just the tip scenario that then went a little sideways. And so, we want to allow that incision to heal before putting pressure. If it splits open, that's not fun for anybody. And then for infection purposes. And so I usually tell people to try not to do anything for like 2 weeks or so. You're going to be sore, you're going to be tired, you're going to be recovery. I usually see hysterectomy patients at the 2-week mark. And so usually this is when this question comes up if they didn't ask ahead of time, or sometimes I'll get a patient message. And at that point I say, if you're interested in doing external stimulation, go for it. If what I would recommend is, again, nothing in the vagina, and we review why. And then I just say, take it slow and easy. Some patients, when they orgasm, that still involves some core work and some muscular exertion, and to stop if anything hurts. And otherwise, have fun.
Yeah. And for, testosterone tends to decrease the elasticity of all of the vaginal mucosa and all of that kind of stuff. And so we definitely see some, particularly in patients who maybe were like, as we would call in the community, size queens or interested in like larger penetrative receptive sex.
Yeah.
We see some loss in like volume, right? Because of loss in elasticity. Do we have any effects like that after like hysterectomy procedures?
So I think in studies, there's maybe a tiny amount of shortening in the length of the vaginal canal after hysterectomy. And depending on the closure, it may lose like a centimeter or so. I'm not actually aware of any specific studies about like, folks that are engaging in larger penetration, having changes in elasticity. It's more a change in length that is going to change after hysterectomy. And then, depending, the cervix may or may not. I'd say most of the time we remove the cervix. And a lot of folks are interested in that because then they don't necessarily need cervical cancer screening going forward. And so that's really where the change in length comes from. But there shouldn't really be any change in elasticity.
Yeah. Do you, before people like decide what to do with their cervix, do you talk about like what their interest is in cervical stimulation during sexual activity?
I'll bring it up. I'll usually talk about pros and cons. And I think one thing that patients and probably providers do get confused about all the time is that when I talk about a total hysterectomy, I mean uterus and cervix. And a lot of times patients will come in and think everything, and they'll come in and say they had a partial hysterectomy. And I'm like, but your cervix is gone, So I always try to be careful about making sure we're talking about the same thing. And then I usually talk about total versus subtotal hysterectomy and kind of what the pros and cons of leaving the cervix in are. I think a minority of patients will elect to hang on to their cervix, but it's an option.
Yeah, and I think this is one of those language is like one of my big things in our being like part of the trans community, then being a clinician, and then kind of like the colloquial way we use vagina to mean vulva, like drives me up a wall.
I catch myself say vagina in the clinic when I mean vulva, and I'm like, I should know better.
And I think so in our field, right, people say vaginoplasty all the time. And I'm like, do you want a vulva vaginoplasty or do you want a vaginoplasty, right? Because they're actually two
vaginectomy
or just a vulvoplasty, right? My patients and I often talk about the difference between like a BLSO and hysterectomy and whether or not you like keep your cervix or not. And so as referring clinicians, I do think like helping our patients understand the language that they might find in their surgeon's office is one of the like roles we can help like support our patients with. Because some surgeons are really great at breaking it down and some surgeons are less good at it.
Absolutely. So appreciate it. Because that also, it's nice because, of course, when we're going through the thing, I have kind of my checklist of things that I try to go through. But, if I kind of get off track or whatnot, then it's nice when the patient is like, oh, hey, I actually did want to ask about if it's possible to keep my cervix or what to think of, what are the considerations there. And so that's super helpful.
Yeah. Yeah. I usually give my patients like a pre-surgical, like ask your surgeon these questions list, but it's kind of a general like thing. It's not tailored to each surgery. And that's like something I could think about like dialing in over time for different surgeries. Just one more thing on my to-do list, but I'm going to write that down because I think it's a great idea. And then, okay, I have more questions. One of the things we come up all of the time in our field around surgery is BMI restrictions that we don't see come up in patients accessing surgery for other health conditions in the same way, right? Like there is a lot of kind of seeming thought that like these gender affirming surgeries are in a way more elective than surgeries we do for other things like for cancer. And so that there's a lot of tension in our community around that. And I think I'm curious, like for a minimally invasive approach, do you have any kind of thought about patient size, body size?
We actually, and I will say in gynecology land, I have seen this even in kind of the cisgendered population for folks that are looking for surgery for kind of bleeding, pain, that sort of thing. And, again, this kind of is where folks that maybe do less surgery are less comfortable with people with bigger bodies. And so, there was a surgeon that I knew in training that if somebody had a BMI over 40, they would essentially kind of really try to stonewall on care or surgical management of like hysterectomy for kind of any reason whatsoever. And you kind of run into the same thing where, a lot of gynecologic pathology isn't, especially benign gynecologic pathology is not necessarily going to shorten your life. And a lot of it is a huge quality of life burden. Which is unfortunate because people with abnormal bleeding have a worse quality of life than people with breast cancer when they look at the data on that. And so I have lots of opinions about that in general, but it's not something that's necessarily limited to gender affirming care, but certainly runs into some of those same barriers. I think it's myself and my partners, it's a case-by-case basis. And it really comes down to a discussion with the patient. Specifically for gynecologic surgery, because we operate in the pelvis, we have to put patients in Trendelenburg in order to access the pelvic organs and get the intestines out of the way. And so for folks with a bigger body mass, some of those patients, we tip them up backwards and the weight of the abdomen rests on the diaphragm and the chest, it can be more difficult to ventilate those folks. And so it really ends up being an anesthesia issue. There's a lot of tricks that we have to try to work around that. And then I also talk to the patients that, you might have higher risk of wound complications. You might have higher risk of DVT or things like that after surgery compared to somebody, or in risk of infection compared to somebody with a smaller body mass. But it doesn't necessarily mean that they absolutely cannot have surgery. I generally don't think that, a blanket statement of never is a good idea. But I've seen some patients that came in looking for a gender affirming surgery, and they, because of their other medical conditions, like couldn't lay flat in the office. And so, for example, that's not somebody that's going to be able to tolerate a surgical procedure in Trendelenburg versus somebody who might walk in with the exact same BMI, maybe distributed it differently, has a different kind of other comorbidities and whatnot, and might be able to tolerate surgery okay to get that done.
And do you work with, because you're here in Seattle, so bigger urban area,
Yeah.
more access to more clinicians.
Yes.
What is I know that I'm going to show some of my ignorance of our larger field, but anesthesiologists who have training to work with people with larger bodies, how many of them are there? Where do we find them?
I would say probably the easiest way if you're just kind of looking is anywhere that has a bariatric surgery program where the general surgeons are going to be doing a lot of bariatric procedures. That's probably the easiest way to find that anesthesia population. And then aside from that, I think it's hard to, I guess I actually don't really know how you would go about screening the anesthesia department at another institution aside from, phoning a friend.
Yeah. Because definitely I find as a referring provider, one of the things that we have all had happen, and one of the things I actively work to try to avoid is to refer someone who then to a surgeon who then says I'm not going to operate on you because of your size. That's super traumatic, right? And so I have a list of my surgeons. I have their a lot of my preferred referrals have a similar statement as you do, that it's a case-by-case basis. Versus I have other surgeons who just have a hard BMI cutoff. But I think I've definitely run into the where the surgeon was this would probably work, and then the anesthesiologist was I'm not doing this case. Right. And so it was even worse from a patient trauma standpoint, because they had some hope from the surgeon, right? And then it was just kind of no. And so I'm wondering, this is where I'm getting in the weeds, and I will eventually move off of this topic, but I'm curious, how many times do you see surgeons like yourself or just other surgeons in general who do gender affirming procedures partner with anesthesiologists that they don't regularly work with, who work in a bariatric center? I'm sure there's so many moving pieces of pulling people out of different systems to make that happen.
And I think it does come down to how your system's set up. So, for example, at Virginia Mason, we're all employed by the hospital. There's like the anesthesia department, and I kind of know all the people, or at least have encountered them on a day-to-day basis. And they might say, hey, this person is not a good person to do surgery at the ambulatory center, for example. They should be at the main hospital. I think where it gets tricky is when people are operating in if they're in private practice and they operate at the hospital where they may have an anesthesia contract group. And I think that's where those moving pieces get more complicated compared to kind of a closed system, which also has its negatives on occasion. But at least, we tend to have a better knowledge of working relationship with our groups. And I think that's, again, going back to structure of our healthcare delivery system that can be frustrating for everybody.
Yeah. So definitely kind of one of those things as a referring provider to keep in mind, like when we're referring to clinicians with private practice who operate in ambulatory day centers, like that might be less of a option for people with larger bodies. So like really to clarify before we go there.
And a lot of
an academic institution or a large employed system.
Yeah. And I will say, because like our ambulatory centers, they have a hard cutoff for BMI where you're not allowed to schedule patients there. And, again, we can certainly debate back and forth whether that's appropriate or not. But I think part of the idea is to avoid somebody showing up and the anesthesia person being like, this isn't the right place for it to do this surgery.
And then as far as like, part of what I'm trying to do in my work right now is like really think about incorporating like inclusivity like through everything I do, as opposed to just kind of like as a end notes. And so I really like I'm curious, because I obviously like we know in obstetrics, right, like more Black women die in childbirth than white women. Like that's the undebatable fact that we have like well documented. What do you see in like accessing surgery? Because like also one of the things, right, that happens to Black people all the time is that their pain is not considered
valid or
value.
Yeah. I think the biggest thing we see in my area is so Black folks tend to have fibroid disease more commonly. So in general population, 70% of people by 50 will have a fibroid on their uterus. But we know Black folks tend to get fibroids more likely, so like more like 80-90% by age 50. And they're also more likely to have a significantly higher burden of fibroid disease, and also a more, they show up younger. And so that can cause a big burden on folks, both from a pregnancy standpoint and from a just, general life standpoint. And the problem there is, one, I think they, for all of the reasons you noted, tend to get put off or diagnosed later. And the other problem is they tend to get open procedures more often than minimally invasive procedures. And some of that is because, again, their fibroid burden is bigger. And even if they're asking for something like a myomectomy, so removing just the fibroids, a uterine sparing procedure, sometimes they are more likely to get an open procedure. And some of that is just a pathology-based problem, but some of it is also an access to care problem. And I saw abstract recently where even in patients that were having surgery for adenomyosis, Black women were more likely to get an open procedure, an open hysterectomy, compared to a minimally invasive approach. The other thing there is for patients that have a big fibroid burden, they're often told their only option is a hysterectomy, and then a myomectomy or a uterine sparing procedure is not an option. And so one thing, when they started coming out with uterine transplants, I guess I shouldn't put that in quotes, but as a thing, the kind of original target demographic for that was folks that had uterine agenesis or MRKH syndrome. And when they started looking for people that were interested in undergoing that procedure, a lot of the folks that were showing up were people that had their uterus, like a hysterectomy for fibroid disease or something else, and were, still wanting the access to fertility. And so that's a big one where, unfortunately, those patients are getting a hysterectomy instead of a myomectomy, or are not engaging with care for 100 different reasons, partially because one of my the folks that trained me and did a ton of fibroid work would say, I would have patients that would say, well, every doctor I saw told me I needed a hysterectomy. So I stopped going to doctors, and now I'm here with my fibroid, my uterus up to my xiphoid. And so, that's probably somebody that's going to end up with an open myomectomy, but that's certainly still an option, and somebody who feels comfortable with that skill set. So
yeah. And we've definitely like veered a little bit into like more cis population, and trans people of color can have fibroids as well.
Absolutely.
And a lot of my listeners are primary care clinicians. And so I think like what I'm really pulling out of this in my mind is like, when it's possible, like access to care is always hard, right? And in populations that is marginalized, access gets harder. And then the time off of work to access multiple opinions gets harder. But it sounds like definitely like encouraging multiple opinions, or having, as the referring clinician, vetted like the people we're referring to know like where are their rates of hysterectomies in their Black patients versus their white patients for the same condition, right? And like, there may be some pathology basis behind that, but also like explain the discrepancy in rates to me and help me understand why it's happening. And like, does that feel valid to me as a clinician who has like pretty decent clinical reasoning, or does it feel like, implicit bias and like unexamined racism, right? And institutional racism, which is like very present in our work. And those are hard conversations to have as a referring provider when you're talking to a surgeon, because like oftentimes the power differential between us feels like present. Some surgeons are more approachable and less approachable, but in my mind, if the surgeon can't have that conversation with me, they're not going to treat my patient well enough that I want to send them there if I have another option. Because like, while they are hard conversations, if we don't start having them, these rates will never change. And so I just like tend to think,
and if the person's just like, what do you mean there's different rates? Like that's also a problem.
That's also concerning.
So, I think there's half of solving a problem is understanding that you have a problem to start with. And certainly there's still a lot of work to do, but
I feel like I could talk to you for like 7 podcasts. So I'm going to try to like circle back to like one of our other questions, which was definitely like, let's talk about some tips and tricks. And like this episode, gosh, I had so many other questions I wanted to ask Dr. Wagner, and like we haven't even talked about like a neovagina. And you brought up like uterine transplants, which I also have lots to say about. Like, and I'm not going to get to any of that today, but I definitely would love to take some time. I think tips and tricks for trauma-informed pelvic exams is like great for community clinicians. So like, what are your thoughts about that?
So first of all, sometimes I'll just say at the beginning of an appointment or a new consult, like, a pelvic exam will probably be helpful at some point in this. We don't have to do it today. And that gives some patients will just spend the entire appointment or like just laser focused on the possibility that they may need to have a pelvic exam. And sometimes just saying, you know what, we don't have to do that today. It may be part of it. Sometimes it's easier to come back at a later date and do that. And so that's kind of the first thing, is to say, we don't have to do that today. The second thing is, when I try to ask new patients or patients that I haven't examined before, like, do you have a history of any sexual trauma? And specifically because folks with that sort of history often have more challenges with pelvic exams or gynecologic procedures. Is there anything I need to know about you to take care of that? And so some folks will say, yes, I have a history, but no problems with exams. And some people will say, like, yes, I have a history, and yes, exams are challenging to me, or I've never had an exam. And trying to kind of get a sense for where they're coming from is always the first step. And then I usually tell folks, is it helpful for me to talk the whole time? That's generally my default, just because, people are jumpy and can be, and knowing what to expect is half the battle. I always tell people, like, you say the word and I will stop. There's something that we have to do sometimes in a procedure that, I tell them I'll stop if I can. And, sometimes there's things that are going on that you may not be able to stop immediately, but that's a minority. And then I offer them to, if they want to listen to music, if they want to have a support person there. I almost always have a medical assistant with me for genital exams. And so some patients will actually prefer not to have a chaperone, and that's okay with me. And then having access to tools. So kind of depending, the pediatric speculums, the long skinny ones can oftentimes be, they don't come in a plastic, so they only have the metal ones. And so, I just talk through, what part of the exam we're doing, what we're looking for, what I'm doing. And I think reading the patient. So, I see all the time, I work with medical students and trainees a lot where, you touch the inner thigh of the patient and they squeeze their knees together and you can see all of their muscles clench up, and that is not the right time to try to put the speculum in. And so just kind of being aware of what's going on. So a lot of times I'll really focus on, and I think one thing that I've learned a lot about in the last couple of years is trying to avoid kind of reflexive comments like relax, which, it flips out on occasion now and again, but really trying to retrain myself to use language that's not potentially triggering like that, and focus on letting knees soften and knees fall away, letting the bottom sink into the table. And then kind of one thing that I do a lot is, I'll expose the introitus and then I'll just touch with the speculum. I'll say, okay, you're gonna feel the speculum here, and I'll touch. And if you touch and they go, then you pause and say, okay, take a big deep breath, blow it out. And I'll just leave the speculum just touching the introitus right there and see if I can get them to soften all their muscles again before trying to insert. And that can sometimes make a huge difference in comfort. And so, it's complicated though.
Yeah, I love all of those things. I think, I'm telemedicine based now, but when I was still doing in-person care at my clinic, I was in clinic when Trump was getting elected. And so the number of IUDs I had to put in skyrocketed. And I think also being like a femme presenting person, you just end up with more people. And so the number of pelvic exams I've done in my life is very bad. And I think, some of the things I always think about that I think are especially pertinent to trans and gender diverse patients. And this can be harder in a busy practice. I understand, as I've done it, we've had these 21 appointments, we're seeing 22 people a day. But I always meet my patients with their clothes on. I have met my doctor myself in a paper gown, and it does not feel good. And similar to you, actually, not only do I say we don't have to do the pelvic exam today, one of the things I say in every visit I do is that I think consent is essential, and that this is your body and you get to say what happens to it. And that if, and in primary care, it is rare that I would be doing something that I could not stop. I did do colposcopy. Exactly. And sometimes if someone was bleeding, obviously I would have to attend to the bleeding before I could stop what I was doing. But outside of that,
kind of a standard exam.
Yeah. And so, and also, right, sometimes when you pull off the, I can't remember what that clamp was called we used when we did to clamp the cervix now, but that would bleed. But otherwise, I'm going to be able to stop. And, one of the things I've seen happen and heard happen many, many times is patients have said stop and clinicians have not. Or not, and it's not, I don't think clinicians are intentionally trying to assault people or be mean or be harsh. But we get so focused on I have to check this box. I have to get this exam done. I have to go see another patient in 8 minutes. And we're this is something we do every day. So it's such a
forget
everyday occurrence for us. And we're I'm so close. We're almost done. And that's what I always hear. I hear someone said, I asked them to stop and they were I'm almost there. I'm just going to finish. And that is always one of my cautions to clinicians. If they have told you to stop and you have said that to them, that is technically assault. I know that sounds harsh, but really that's what that is. It just, we don't think about it that way because we're so used to this being a normal part of our lives. And I'm a queer person who has access to a lot of healthcare, who has had clinicians like try to continue with exams when I have told them to stop. And like, they didn't know I was a physician, and I'm like, absolutely not. Like, I have told you not to touch my body. Do not try, and do not try to talk me into it in like a cajoling, patronizing way. If you want to have a conversation about my risk and benefit of why you think this exam is important, we can do that. But like, don't do this thing that you're doing right now. So that's like one of my big things.
You're absolutely correct.
Yeah, it's like can sound intense, but I think again,
but I think that just it's important to use that sort of language to underscore how important it is.
Right? Because it is like I understand both sides. Like I've been that clinician that is trying to fit 22 patients in, and like get this person's IUD in and get them out of the office. And then they just like also vagaled. And I'm like, okay, now we're sitting here for an hour. So I understand that side of it too. But like trans people's bodily autonomy is assaulted every day. Every day we are told we do not have a right to our body. We are told that by the news. We are told that by the media. We are told that by our legislators. And then as a femme presenting person, I am told that by like everyone else in society who thinks they have a right to my body when I do not, just because I chose to wear lipstick today. And so I actually ask my patients, and I especially emphasize this with my kids, to say no to medical things with me in a safe environment so they can have that practice when they know the clinician is going to be supportive of it. Because at some point, they are going to be asked to do something, that is not because it's medically necessary, but because of someone's like morbid curiosity. Every trans person in my life, every trans patient, every one of my partners has had a medical provider of some fashion ask them like for genital exams or to take their pants off, or whatever, when they're there for like, a URI or ear pain or like a sprained wrist. Like everyone has that story, like every single one. Like I haven't done a research study on it, but like
anecdotally
it's too high. And so I ask them to practice saying no when it's like they know it's going to be well received. So that's another approach I use. And then, definitely we talk about like, this is what a pelvic exam will look like. Yeah. Do you want me to talk through it? Or do you want to like listen to music? Do you want to bring a support person? Do you want to bring a comfort item? Like, do you want to have like a stuffed animal, a blanket, a fidget toy? Like, do you need a Xanax? I'm like, I don't like Xanax for many things, but before exams, for flying and before MRIs, I will hand them out. I'm happy to do that. Right. All of these things. And then a lot of times in primary care, because like, again, the exams we're doing probably less skill-based, less like tools and instrumentation is going to happen. So like actually hardly ever use stirrups, like, or we don't even call them stirrups anymore, footrests. But typically just have people actually like butterfly their legs out with a bolster up under their hips. And that like also like loosens, I've found like loosens everything much better than footrests do anyway. And then
it's like harder to let your knees flop together if you put yourself in butterfly.
Right. And then checking every step of the way, like this is what I'm going to do next. Is that okay? Like if that's what they've said they want, because similar to you, my default is to talk through the whole thing. Unless they told me they don't want that or they want to listen to music or something, like I'm checking every step of the way. And then I often like, if I see that, right, when I worked with learners, like when something happens and everyone, like we see all those muscles tense up, I'll say, I noticed all of your muscles tensed up. What are you feeling right now? Like, what do you need to feel safer in this moment? So just observing back to the patient what I'm seeing and asking them where they're at. I don't ask about sexual trauma history as much, just because like in my line of work, almost everyone has had it. So I just function off the assumption that everyone has had sexual trauma that I'm seeing. And so I ask like,
always a reasonable assumption, because there's going to be people that also don't mark the box or don't say no, but have that history.
Yeah. And it like rates of sexual trauma and intimate partner violence are higher in the LGBTQ population, higher in trans patients. I think the like last stat I saw was like somewhere around 3/4 of gender diverse patients have also done sex work, which has higher rates of sexual trauma as well. So just like the rates are so high, I tend to like function off the assumption it's happened, and then really explore more, like you were saying, like what's your experience with pelvic exams? Like what's your interest in doing a pelvic exam? What do you know about why we think you should do a pelvic exam? And try to come again, cervical cancer screening, like we do see more LGBTQ patients and trans patients die from cervical cancer because they don't access cervical cancer screening. But we can do self-collected swabs. It's not the gold standard. We don't have the same kind of data on it. But like, again, there are other options. Yeah, and we can individualize that like screening. I think, one of the things I always saw in primary care, I was at Kaiser, and like we were, you want to check those screening boxes,
Yeah.
and so it's like, and they just had a call center that would call patients and say, you're due for this. And I'm like, that is not true. There is no such thing as due for a screening exam. There is like,
you're eligible for.
You're eligible. It is recommended.
Yeah.
but I hated that language so much because it makes it feel like
you're not.
Like when I swipe my credit card and it says I'm approved, I'm like, can we change that word too? Because it makes me feel like, like I'm seeking your approval and now I've gotten it. But yeah. And so really talking about the fact that like screening exams they're like general recommendations for the greater population, but we should be able to have an individualized conversation with our patient about why we think it's important to them. And then based off their values, whether or not they want to choose to proceed with that.
Yeah.
And alternatives to that, right? Similar to mammography, again, for gender diverse people, right? It's really interesting because I see with some of my patients who are like on estrogen therapy, getting a mammogram is like very affirming. They're very excited to be able to have that experience and to do that. And they're like ready for it. They're like, when can I get my first mammogram? And then some of my other patients, right, who maybe aren't taking estrogen or who are taking estrogen blocking medications or taking testosterone are like absolutely like not interested in doing that. And it's like, yeah, let's talk about screening for these cancers. Let's talk about other options. Like, and some of these aren't options because of insurance, but like we can do other things. Like mammography is not the only option.
And I think the trap we fall into a lot as clinicians is that risks are not destiny, right? And so, when you're talking to somebody, like your risk of this happening is 20% or whatever. Sometimes we kind of think, 100% you're going to get this thing, have this, say breast cancer, for example, like you're definitely going to get breast cancer. Your lifetime risk is 20%. And you're like, well, actually the majority of people will not get breast cancer in that scenario. And so, I think it's important to talk about like risk specifically because everybody will evaluate that risk very differently
Right.
in all of those scenarios.
It's so true. Right. And I think, those are conversations as referring clinicians. It's so hard to have because again, I know we're on this time schedule, we're on this budget. And like, one of the tools I used when I worked in a more traditional practice and still did this was like set up this expectation with my patients that like, we only have time to handle one issue, like per appointment, right? We only have time to like really give it the time, attention, and like quality that it deserves to give you the best quality of care. And for some people, that's like really impossible because they can only get off one day every 6 months to see a clinician. And so like, I would talk about like to do my job to the best of my ability, I can do one thing in this appointment. And then I would want you to come back for all these other things. That can be a virtual visit. It can be a telehealth visit. It can be a phone call. But if we try to squeeze all these in, I'm not going to be able to do my job to the best of my ability. And you might have suboptimal care. How does that feel like given your time and energy that you have to invest in this? And like helping them understand like the limitations of my time and my expertise and the system, and then helping them choose like how they want to navigate it. Right. Is just like, I always felt like if I did that work up front, it made everything else a little bit easier. Yeah.
Setting expectations is always better for everybody.
Oh my gosh. Okay, I took up all of your time and like didn't get to all the questions, but like thank you so much.
Of course.
I feel like I'm like we'll probably pester you another day to come back.
Yeah, no, honestly, I'd be happy to. So this was fun.
This was so informational and so helpful, and I feel like there's so many other things I wanted to ask you about. But yeah, thank you so much for your time. And Dr. Wagner is at Virginia Mason in Seattle for anyone who's in the greater Seattle area. Y'all take all health insurance, so can take referrals for anyone who is interested in minimally invasive gynecology. And sounds like also for anyone who's been told that they're not a candidate or that, to do an open procedure, maybe getting a second opinion would be great as well.
And I would say also patients that are told they cannot have a tubal sterilization or hysterectomy based on age. That's another one that comes up a lot.
Oh, yeah. Oh, yeah. I had that one. I was like, I'm ready to do this. And everyone in Florida was like, you're too young. And I was like,
That's a whole other can of worms.
That is. Thank you so much for your time. Have a great day.
You too. Thank you so much.
Bye.
Bye.